gentlemen. I hope I'm audible and the slides are visible.
Yes, please go ahead.
Thank you, ma'am. So I thank AOS Santen for this invitation, and also for a topic which is very rarely spoken about. So we will try to understand why that is so and what all we know about this side effect of the prostaglandins. So this is prostaglandin associated periorbitopathy, which is called PAP. These are my financial disclosures, nothing particular to the topic which I'm talking now. So in this talk, we will briefly discuss about the definitions and the mechanism of PAP, the incidence and prevalence of PAP, the impact of PAP on glaucoma management, how do we manage it, and the summary of it. So PAP is probably one of the most recently defined side effect of prostaglandins. So it was in 2004 that Paplinski and Smith came out with the first report of deepening of the upper eyelid sulcus with topical bimatoprost therapy. And I think that's from when a lot of people started recognizing this side effect. So if you look at the couple of examples which they had mentioned, I will probably take you through the second example here. Here is the patient who was started on bimatoprost therapy in the left eye, and this arrow points towards the deepening of the upper eyelid sulcus here in this eye, which is very conspicuous when compared to the other eye. The patient was subsequently challenged with bimatoprost to her right eye. That's when the right eye also started showing the deepening of the upper eyelid sulcus. And then subsequently, when bimatoprost was discontinued, this deepening regressed. Subsequently, as I said, a lot of people started noticing these side effects. And in addition to this, this deepening of upper eyelid sulcus is commonly called as dews. In addition to this, there were certain other changes seen in the eyelids and around the eye in patients on long-term prostaglandin analogs. And together, all these signs were put under the definition of PAP. So essentially, the definition of PAP is all that side effects of PGS that occur around the eyelids. And these are the 7 signs of PAP. One is the upper eyelid ptosis. Second is the dews. Third one is the involution of the dermatochalasis. Dermatochalasis is the excessive skin in the eyelid, and the involution of this is seen with prostaglandin analog use. Orbital fat atrophy, mild enophthalmos, flattening of the lower eyelid bags called phlebs, and inferior scleral show on a tight orbit. Here is an figure which shows most of these signs. See, this patient is on prostaglandin analog to the left eye, and we can see the mild upper lid ptosis here, deepening of the upper eyelid sulcus, involution of the dermatochalasis. If you look at the right normal eye, which has this excessive skin here, that's absent on the treated eye. Orbital fat atrophy, which also gives an impression of mild enophthalmos. Flattening of the lower eyelid bags. This is the flattening seen in the lower eyelid here compared to the normal eye. And then the inferior scleral show on a tight orbit. What's the mechanism of PAP? So the mechanism of PAP essentially is anti-adipogenic effect of prostaglandin analogs. So PGAs inhibit adipogenesis and cause adipocyte atrophy, and that's now established as the primary reason for PAP. There are multiple other basic science experiments, which have once again showed this mechanism. Here, in an interesting study, the transcription factors which were responsible for adipogenesis were studied, and the effect of multiple prostaglandin analogs on these expression of transcription factors were analyzed. And what was found was that bimatoprost and travoprost reduce the expression levels of these adipogenic transcription factors. So the control bar is here, and the reduction in the transcription factors with travoprost and bimatoprost is shown here, which is found to be very significant compared to latanoprost. If you can look at this graph, we will discuss that subsequently. The other way of looking at the anti-adipogenic effect of prostaglandin analogs is to look at the differentiation of pre-adipocytes to mature adipocytes. The mature adipocytes take up oil red rose staining very well. Here is the control, which is taken up oil red rose staining, which stains the intracellular lipids. So in the differentiation stage of this pre-adipocytes, if they are treated with prostaglandin analogs, you see very, very less number of mature adipocytes, be it latanoprost, travoprost, or bimatoprost, even tafloprost here. But uniprostone showed very little effect on the adipogenesis, for that matter. So what's the onset and prevalence of PAP? So most of these studies on PAP are from Japan, for that matter. PAP has been studied extensively in Japanese patients, not to that extent in other patients. This was an interesting study where the incidence of PAP was compared in patients on multiple prostaglandin analogs. And what they found was in glaucoma patients who used bimatoprost, close to 60% of these patients showed signs of PAP, or DUEs for that matter. 50% of those on travoprost showed the presence of DUEs, while the number of patients on latoprost and tafloprost showing this side effect was much lesser, as well as uniprostone. So also there are other couple of studies which showed that shows the regression of PAP when the patients were shifted from bimatoprost to latoprost. So in this interesting study, who had presence of PAP and were on bimatoprost, they were shifted to when they were shifted from latoprost to bimatoprost, close to 60% of them showed DUEs. So which essentially tells the fact that the occurrence of PAP is more common with bimatoprost compared to latoprost. In addition to Japanese patients, there's one more study from Turkey, which also looked at the onset and prevalence of PAP in their patients on bimatoprost, latoprost, and travoprost. And what they found was the incidence of PAP was very high, once again, in those using bimatoprost. So 93% of patients on bimatoprost showed some of the signs of PAP, while only 40% of those on latanoprost showed signs of PAP, while those on travoprost showing the signs of PAP were 70%. So that was between latoprost and bimatoprost. Also, this study found that the presence of severe PAP essentially referred to DUEs, while mild PAP referred to the fat atrophy, things like that. So it was severe PAP, once again, was more common with bimatoprost compared to latanoprost and travoprost. The first sign which was noticed, the first PAP sign which was noticed was, in fact, periorbital fat loss. Very interestingly, this is the only Indian study which I could come across, longitudinal Indian study, which looked at the prospective study, sorry, which looked at the incidence of PAP in Indian patients. So this study followed the patient for 6 months and evaluated the occurrence of PAP. And what they found was that there was a small study with 32 patients, 63 eyes. If you look at the initial visit here, it was only 6% or 4 eyes. 6% of the eyes had signs of dews, while over the follow-up period of 6 months, 35% of the eyes showed signs of dews. So all these studies also show the fact that PAP or dews or any of the signs of PAP generally occurs anywhere between 4 to 6 weeks from the from the time of starting the prostaglandin analogs, and they can manifest anywhere up to 6 to 9 months after starting the prostaglandin analogs. That's the general onset period of PAP. Now, what's the impact of PAP on glaucoma management? One is the cosmetic influence of this. This can affect patients' social life, confidence, quality of life, especially if the prostaglandin analog is prescribed to one eye. This, in the long term, can affect the adherence as well. The other one is the pseudoorbital pathology, which is associated with it, which may require some management as well if the patient is concerned. But what's more important from the glaucoma management point of view is the effect of PAP on the intraocular measurement and the effect of PAP on the surgical outcomes. IOP measurement, the tight orbit, tight lids themselves can cause a problem in the precise intraocular measurement. This was once again a very interesting study which compared the intraocular pressure measurements with GAT and eye care in those with tight orbits due to prostaglandin analog use. It had a control group of 70 subjects, where the difference between GAT and eye care measurements for the intraocular pressure was 1.3 millimeters of mercury. So essentially, eye care measured the intraocular pressure 1.3 millimeters of mercury on an average, less than that measured with GAT. But in the group with tight orbit syndrome, the intraocular pressure measured by eye care was on an average 8.6 millimeters lesser than that measured with GAT. So what this indirectly tells is that the GAT possibly overestimates the intraocular pressure in eyes with tight orbits or tight lids, for that matter. So this can affect the measurement of intraocular pressure and the decision subsequently. How does PAP affect the outcomes of glaucoma surgeries? We all agree that we have seen patients with tight eyelids when we are trying to take their intraocular pressure measurements, when we are trying to manipulate the globe during the surgeries, or when we are trying to manipulate the globe for laser suturalization. So, but does this affect the outcome of the surgeries too? Once again, a very recent study showed that the probability of failure, which essentially is defined as the increase in intraocular pressure after the glaucoma surgery, the trabeculectomy here. So the probability of failure or increase in intraocular pressure was much higher in eyes which had dews before the surgery. So what it essentially meant is that the presence of PAP can adversely affect the outcome of trabeculectomy. There's a small retrospective study, and longer studies would definitely throw more light on this. So how do we manage PAP? The simplest is to shift the patients to other class of anti-glaucoma medications which don't cause this side effect. However, then we are denying the patients of the other benefits of a prostaglandin analog in that case. The other method is to shift them to the other prostaglandin analog. Here are a couple of studies which shifted the patients either on travoprost or bravoprost or bimetoprost who showed signs of PAP to latanoprost, and a lot of these patients showed recovery of the PAP signs. So here are the examples. Here is the patient who has dews, both eyes. This is after shifting the patient from travoprost to latanoprost. Dews much better, and at 6 months, we hardly see any signs of dews here. Another patient with unilateral dews subsequently improving after shifting from travoprost to latanoprost. So another study quantitatively showed the effect of shifting from bimetoprost to latanoprost on the symptoms of dews, and what it showed was close to 85% of the patients who were shifted from latanoprost to shifted from bimetoprost to latanoprost who earlier had signs of dews showed improvement. So this is negative dews after shifting the patients from bimetoprost to latanoprost. So a significant percentage of patients, when they are shifted from either bimetoprost or travoprost to latanoprost, show improvement in their signs of PAP. So the other way of managing patients with PAP is to shift them to a novel class of medicines called EP2 agonists. So the commonly used prostaglandin analogs are FP2 alpha agonists, but a new class of EP2 agonists have very little effect on the adipogenesis and therefore have no or very little PAP occurrence. One of the commercially available EP2 agonist is called the OMD, or the omidinipag isopropyl. Ibelis is its commercial name. It's marketed already in Japan. So this, once again, is a basic science experiment which showed very little effect of EP2 agonists on the differentiation of pre-adipocytes to mature adipocytes. Here is the undifferentiated adipocytes and the differentiated adipocytes taking up oil redwo staining very well. When treated with latanoprost or prostaglandin F2 alpha, they don't mature into adipocytes, while those treated on omidinipag, which is the EP2 agonist, showed good uptake of oil redwo staining, which essentially tells that EP2 agonists have no effect on the differentiation of adipocytes. There are clinical small case series which also show that when patients with signs of PAP and on latanoprost or travoprost or bimetoprost were shifted to the EP2 agonist, a good number of patients showed improvements in the signs of PAP. So in summary, PAP in Indian context definitely is an under-recognized and under-reported condition. We need to understand that it can affect the patient care in many ways. It's important to be mindful of its occurrence and probably carefully look for it in all our patients. Thank you.
Thank you, Dr. Harsha. So the last talk will be given by Dr. Vinita, who will talk